Okay, here we are again, chapter 2, the biology of behavior, biopsychology. Um, I have to tell you again, I'm not a biological psychologist, I'm a social psychologist, um, but I appreciate the biological foundations of pretty much everything that we cover this semester. Everything can be reduced down to the things that we're going to talk about in this chapter. I just personally am more interested in the end result of all the biology, particularly in terms of how we interact with other people, and that's the reason why I prefer social psychology. But you can't be a legitimate, self-respecting psychologist today without having at least an appreciation for the biology that exists as a foundation for everything else that gets studied in this discipline. This chapter will be a little difficult for some of you who are not really biologically interested or inclined. And for some of you, a few of you at least, you'll find that you know a lot of this already. In fact, I think a lot of the basic information that I'm going to give you today, you learned in the 7th or 8th grade, maybe in high school, and it may be a refresher. But chances are you've forgotten all of that stuff if you're not really interested in biology. Anyway, some of you will do really well in this chapter. You'll like it a lot, and others won't like it. That's kind of the nature of this kind of chapter. Okay, so there are two major communication systems that exist in our bodies that allow us to communicate with the outside world and allow us to communicate within our bodies. And the one that we're going to spend all of our time on today is the nervous system. So the nervous system is the faster of the two. It uses electrical impulses and neurotransmitters. It involves everything that we do. The second system is slower. The endocrine system is a slave of the nervous system. It uses hormones that flow through the bloodstream, and so it's going to be slower as a result of that. So the endocrine system is involved in some things. Motivation drives our sexuality, emotions, and of course the nervous system is involved in those things as well, but the endocrine system is also used in a major way in those kind of processes. But again, the nervous system is involved in everything that we do. So I would say it's more important to know the details about. So particularly this part here might be the review part for many of you. There are 4 basic parts of a neuron. First of all, there are dendrites. The neuron is the basic building block of the nervous system. The nervous system is basically made up of a whole bunch of neurons. They all pretty much look and act the same. They'll have dendrites, which are the receivers of information from other neurons or from the sensory organs that are taking in information from the environment. Every neuron is going to have many dendrites that act as receptor points for information to come into the neuron. This is always the front door of a neuron. Dendrites surround the cell body of a neuron. So the cell body is where the metabolism of the neuron is going to be maintained. This is the life of the cell. So neurons are like every other cell in the body. It has a nucleus, it has DNA, it has RNA, it has things that maintain activities that maintain the life of the cell. For our purposes, talking about a neuron, the cell body is also involved in basically sort of weighing the input that's coming in. So some of the information that's coming in via these dendrites is excitatory, meaning it's going to push this neuron to fire a message to the next neuron. Some of the information coming in is inhibitory, meaning it's going to push the neuron away from firing a message to the next neuron. So what the cell body does, and it's kind of a mechanical process, it basically just weighs the amount of excitatory and inhibitory information that's coming in. And if the excitatory information is greater than the inhibitory information, so much so that a threshold is passed, then the message is sent to the next neuron. If the inhibitory information is greater than the excitatory information, then that wins out and the message is not sent. If a message is sent down from the cell body to the next neuron, it's going to go to the next neuron via the axon. So if dendrites are the receivers of information, the axon is the sender. It's kind of the conduit through which this electrical message is going to flow on its way to the next neuron. So most neurons are going to have one axon, many dendrites, one cell body, and one axon. At the end of the axon, we basically have little knob-like, button-like structures that are branching out. These are called axon terminals or terminal buttons, synaptic buttons, synaptic fibers. It's basically just the end of the axon. So these are the four basic parts of every neuron. In addition, many neurons have myelin sheathing, fatty tissue that surrounds the axon. What this myelin sheathing does is it speeds up the electrical impulse that's flowing down the axon. When we're first born, we have very little myelin sheathing around our axons. And then as we develop and gain more experience, and then according to the biological timetable of human maturation, the myelin is going to be added, and the brain, where this myelin sheathing is primarily going to be, is becoming denser and heavier, and in the process, the brain is becoming more capable. The nervous system is becoming more capable of communicating in the way that it needs to communicate to help us function on a day-to-day basis. So here's whoops, you can't really see it, can you? But when you're following along, looking at the PowerPoint, or you look at it later, you can see that, one cell body, many dendrites, one axon, myelin sheathing that covers the axon, and then the end of the axon's got these little branch-like structures with buttons at the end that connect up with dendrites of other neurons. Okay, can't see that at all. There are basically three broad types of neurons. So there's sensory neurons, which exist in the peripheral nervous system, which is the part of the nervous system that exists outside of this brain and the spinal column. Sometimes the sensory neurons are called afferent neurons, meaning that they send information into the central nervous system from the outside. So they're involving incoming information from the rest of the body into the central nervous system. So the central nervous system exists in the brain and the spinal column. The peripheral nervous system is outside that. The peripheral nervous system is made up of mainly sensory neurons that bring information into the central nervous system, and motor neurons that take information back out from the central nervous system to the glands and the muscles and the organs of the body. So in between, mainly in the spinal column and the brain, you have interneurons. So interneurons comprise the majority of all the neurons in our nervous system, and they're the ones that are most important. They're the ones that make us most human, that allow us to do all the amazing, complex things that we're able to do as humans. Motor neurons are also called efferent neurons. They involve outgoing information, as I said. So afferent neurons, efferent neurons, and then interneurons in between. In a simple way of understanding how these work together, if you put your finger on a hot flame, you can't really see the picture here, but you can look at it later in the PowerPoint, or maybe follow along at the same time with the PowerPoint. If you put your finger on a hot flame, the dendrites of the sensory afferent neuron are going to pick that up. They're going to send information about that across the axon of that sensory neuron. And it could be just one, it's not going to be, but it could be just one sensory neuron picking up that information, sending its information down its axon to the spinal column. So picture a neuron that's maybe 2 feet long, going from the tip of your finger all the way into your spinal column. Most of that is going to be axon. So that axon with its synaptic knobs and axon knobs is going to connect with dendrites of an interneuron in the spinal column. And that interneuron is going to look just like the sensory neuron, except it's going to be much shorter with a much shorter axon. Its axon and axon knobs connect with dendrites to a efferent neuron, a sensory neuron, a motor neuron, that's going to take the information back out to the muscles in your arm and hand and finger to be able to cause you to withdraw your finger from that hot flame. Of course, that's a reflex. It doesn't involve information going to the brain. You can still act on it, even if the information doesn't go to the brain. Of course, there's going to be other neurons that connect with the interneuron in the spinal column that take information back up to the brain so that you can eventually feel the pain, but you act on it even before you feel the pain, because there may, in its simplest form, be just one sensory neuron that connects with an interneuron in the spinal column and one motor neuron that connects from there back to the hand to make you withdraw your finger from the flame. And if you understand really the processes involved in those 3 neurons, a sensory neuron, a interneuron, an interneuron, and a motor neuron, then you have the ability to understand the processes that occur in everything that we say and do. So see and do. You may see something, information is taken in via neurons to your brain from your eyes. That causes you to think about something else that's similar to you've seen in the past, and that causes you to conjure up certain emotions based on your history and the kind of person you are. And all those processes involved are just working in the same way that a sensory and a motor neuron and an interneuron in between are acting when you put your finger on a hot flame, or the doctor hits your patellar reflex in your knee and causes your knee to go forward. It all kind of works the same. Now, other major parts of this process, let's talk about the action potential. So the action potential is the electrical impulse, the message that's created when excitatory information outweighs inhibitory information, and the message is sent to the next neuron. The action potential can only occur when a neuron is at its resting state. And in its resting state, there's mainly around the axon, there's a lot of sodium and potassium neurons, ions that are positively charged surrounding the axon, outside the axon. Inside the axon, you have a lot of calcium, chlorine, and other anions, large negatively charged ion particles, giving the inside of the axon a net negative charge. So you have what's called a state of polarization. Positive charges on the outside, negative charges on the inside. We describe that in terms of electrical voltage. We describe that polarized resting state of the axon as being at about negative 70 millivolts, meaning that there's more negative charge outside than inside. Inside's positive. So the electrical potential across the membrane of the axon is at negative 70 millivolts. When information is coming in via the dendrites to the cell body, what happens is sodium and in general positively charged ions begin to leak through the dendrites into the cell body, causing that environment to become slightly more positive. So you're going from negative 70 millivolts at the head of the axon to negative 65, negative 60, somewhere along in there. The threshold is crossed, and it's becoming positive enough inside that all of a sudden these sodium ion channels at the head of the axon open up. Normally, the axon is impermeable to large concentrations of sodium moving in, large concentrations of any ions moving back and forth across the membrane. But when this negative 70 resting potential state of the axon moves to negative 65 or negative 60 because sodium ions are leaking in slightly, then all of these sodium ion channels at the head of the axon open up and these sodium ions rush in. When they rush in, they create a brief positive charge. So you're going from negative 70 millivolts to plus 30 millivolts. That brief positive charge that occurs at the very head of the axon when the sodium ions rush in is called the action potential. That's the message that's going to flow down the axon. Basically what happens as that action potential through a wave type process flows down the axon, there are these synaptic vesicles that exist at the end of the axon, in the axon knob area. Synaptic vesicles house neurotransmitters. And that electrical wave that's going to flow down the axon is essentially going to push these synaptic vesicles with their neurotransmitter contents to the end of the axon, the very end of the synaptic knob area. And the neurotransmitters are going to be released from the synaptic vesicles into the synapse. Once the neurotransmitters are released into the synapse, then they're carrying that message. Now it's a chemical message. So in the axon, it was an electrical message. But once the neurotransmitters are released into the synapse, then the message is now chemical. Those chemicals are going to dock into the receptor sites on the dendrites of the next neuron. And that's going to cause sodium ions to leak into that neuron. And it's going to move that neuron from minus 70 millivolts to 65 or 60 or so, crossing the threshold again, and that's going to open up the sodium ion channels at the very head of the axon of the next neuron, and then you have communication from one neuron causing the next neuron to fire an electrical message, which is going to cause it to release neurotransmitters at the end of its synapse, or end of its axon knob, into the synapse between that neuron and the next one. And that's essentially the process. But there's a few more details we got to cover. What happens in the axon once these sodium ions rush in, and you go from a polarized state to a depolarized state. Somehow, in order to be able to fire additional action potentials down an axon, you need to get these sodium ions and potassium ions, which are positively charged, out of the axon. They need to go back out so we can go to this polarized state again and get to the resting state at negative 70 millivolts. That happens through the action of the sodium-potassium pump. So initially what happens is the potassium positively charged ions leak back out surrounding the axon. And then once they leak out a little bit and start the inertia of the electrical potential changing from more negative outside to more positive outside, then the sodium ions rush back out in large quantities. And once they move out completely and you get to this negative 70 millivolt state again, then you have the potential to fire another electrical impulse. Basically what happens is you have wave after wave of electrical impulses flowing down this axon through the action of these sodium ions moving in, potassium ions leaking back out, sodium ions moving back out completely, and then sodium ions moving back in the next section of the axon, and then potassium ions moving out a little bit, and sodium ions moving back out completely. And then that causes the next batch of sodium ion channels to open up further down the axon. Sodium ions rush in, potassium leaks out, sodium ions rush out, and so through this process of sodium ions and potassium ions moving in and out, all the way down the axon, you have the perpetuation of this wave all the way down this axon to the very end, causing those synaptic vesicles to release their contents of neurotransmitters into the synapse to stimulate the next neuron. Now, when the neurotransmitters dock into the receptor sites of the next neuron, we can't just, in the same way that we can't allow these sodium ions in the axon and potassium ions to stay in there, and they have to be pumped back out so that we can get to that polarized electrical potential state again and create another action potential. In the same way that needs to happen, here in the synapse, these neurotransmitters need to do their job, stimulate the next neuron briefly, and then be sucked back up and taken back up into the presynaptic neuron, the neuron from whence they came. So they get taken back up in there, and then they get recycled to be used again. So other action potentials will cause these recycled neurotransmitters to be released. They dock into the receptor sites of the next neuron and stimulate the next neuron, and then they get kicked out. They get sucked back up into the presynaptic neuron, get recycled to be used again. So we call that process reuptake. There's other processes that occur there, basically to allow these neurotransmitters to work briefly and then to be recycled so that other neurotransmitters can take their place and continue this process. But reuptake is kind of the major one that we tend to affect most commonly when we're taking medications for mental health issues or something like that. So both the sodium potassium pump and reuptake are very important to create wave after wave of messages going from one neuron to the next one. And if it weren't for this constant ongoing wave after wave of communication processes going on, then we wouldn't really be able to consistently do the things we need to do to function in our day-to-day lives. It's not just one message that goes down a set of neurons all the way to an end point in the nervous system to create an outcome. It's wave after wave of messages kind of bam, 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 hitting the end of the line, and that causes us to engage in the patellar reflex or the hot flame reflex or the seeing or hearing or touching or tasting or smelling or whatever it is that we're doing. Wave after wave of electrochemical activity is necessary to create the experiences that we have. So this picture, again, you can't really see it on the screen, but you can look at it in the PowerPoint, shows sodium ions flowing in. That creates the action potential right here at the head of the axon. A fraction of a second later, potassium ions are leaked out, and then the sodium ions are pumped out. And so now what was briefly a moment ago positively charged area at the head of the axon is now negative again. A fraction of a second later, further down the axon, sodium ions are being pumped in, and so the action potential is moved from the head of the axon to the next section of the axon. And then a fraction of a second later, those are being pumped out. So now that previously positive area is now negative again. And then through that process, this wave goes down the axon. This picture here, when you look at it, shows synaptic vesicles being pushed through the end of the axon, secreting their neurotransmitters into the synaptic gap, which dock into the receptor sites of the next neuron. Now let's talk about Prozac and Zoloft and Paxil and those kinds of antidepressant medications. Many of you know that these kind of drugs are today often referred to with the label SSRI drugs. What that means is selective serotonin reuptake inhibitors. Now, let's talk about each one of those words in turn. selective serotonin reuptake inhibitors. Those are the traditional antidepressant medications that are used these days since about the late 80s and early 90s. Serotonin, the second S in the SSRI label, is a neurotransmitter. It's a neurotransmitter that seems to be involved in the regulation of emotions. It's also involved in many other things like sleep and a little bit of pleasure, a little bit of contentment and satiation and feeling satisfied. And I guess because depression is related to a lot of those things, we've been able to determine that when somebody's depressed, chances are their serotonin levels tend to be a little lower than normal. Now, I want to make it clear that depression is not simple. It's not simply, when somebody's depressed, it's not simply because their serotonin levels are low, but it is a factor that tends to be pretty common. Now, there's probably many other things that happen when a person is clinically depressed, but depleted serotonin levels is an element of depression. And if we can manipulate those serotonin levels and increase those serotonin levels to a level higher than what they are right now in a depressed person's brain, then maybe we can begin to alleviate some of the depressive symptoms. That's the idea. Now, today there's many other things that are being looked at with depression, but there's still a lot of people who are taking SSRI medications to deal with their depression. What the medications do is they selectively target the reuptake of serotonin in the synapses in the brain in terms of inhibiting that reuptake. So reuptake, again, occurs in the synapse when these neurotransmitters are allowed to do their job momentarily, and then they get recycled back up into the presynaptic neuron to be used again. Now, reuptake is a very important process, but it really only is effective and works the best when you have appropriate amounts of serotonin in your system to be able to take the place of other serotonin molecules that are being reuptaken and recycled. So while that's happening, other serotonin neurotransmitters are going to be able to take their place in the receptor sites of the dendrites of the next neuron. So if you have depleted levels of serotonin, if you can inhibit reuptake a little bit, slow it down a little bit, then the smaller number of molecules of serotonin that somebody might have are allowed to work on the synapse longer. So they may dock into these receptor sites of the next neuron. They get kicked out, but rather than being totally recycled back up into the presynaptic neuron, they're allowed to float around in the synapse a little longer, and then they re-stimulate, dock into these receptor sites again, re-stimulate the next neuron. So in a sense, if you have like 100 molecules of serotonin that you're supposed to have at any given time in a system of neurons that are designed to help you feel content and okay with the world so you're not depressed about it. But if you don't have those 100 molecules of serotonin there at any given time because of bad genes, because of a lot of stress in your life or something else going on, then if you inhibit reuptake, then the smaller number of molecules that you have are allowed to work longer and compensate for the fact that they're fewer in number. If you have 100, supposed to have 100, but you only have 50 at any given time, using that as an example, then 50 can do the job of 100 if they're allowed to work longer. That's the principle of SSRI medications. Now, again, that's not a complete cure for depression. It's not going to work for all people, but the reason why SSRI drugs are considered the wonder drugs of depression these days is because they tend to help about 2/3 of the people who take them. And I want to make it clear, because this will come up later when you do your discussion board posts for this chapter. Most of these drugs that we take for depression are not addictive. We may become a little bit of psychologically dependent upon them, but they're not physically addictive like like the hardcore street drugs that a person might take. They don't give people a high. They just allow people to feel a little less worried, a little less anxious, a little less stressed out about the world. Okay, now the other thing about SSRI drugs is because they selectively target serotonin and not the other neurotransmitters that are in the synapses of these neuron chains in the brain, then the side effects of taking these medications tend to be reduced over medications that were taken 50 years ago. So when these drugs, SSRI drugs, first came on the scene in the late 80s and early 90s, people were able to take them and tolerate them a little more easily than was the case in the past. And so that allowed these drugs to be prescribed for a lot more people, and they became a lot more useful for people who found that the old drugs had so many side effects that it wasn't worth to take them anymore. Now there are still some side effects, and they tend to be dry mouth, constipation, kind of a jitteriness, some physiological things that can occur. Side effects are always going to be existing when you take these drugs in your system, or any kind of drug in your system. But the good news about SSRI drugs is they tend to eliminate many of the side effects, because rather than a shotgun approach where we're affecting everything at the synaptic level, we're only affecting one neurotransmitter. Now today they have SSNRI drugs. Those are selective serotonin norepinephrine reuptake inhibitors, and those are being used in some cases for people with depression or other related issues. Okay, so what this says at the top here is that Prozac blocks the reabsorption or the recycling of the neurotransmitter serotonin, allowing a longer time to work in the synapse to communicate its message. And again, the message is contentment, satisfaction. I'm okay. I don't need to stress. Now, with that in mind, one of the side effects of of Prozac and Paxil and Zoloft and Wellbutrin and Effexor, Celexa, and others, one side effect is that people's sex drive tends to be decreased a little bit. That's a side effect that we can't really get rid of, because if you are satisfied with your life and you're not making a big deal about things as much as you otherwise would when you're depressed, you're also going to be satisfied more often, more readily when it comes to your sex drive. And so the push to be highly sexually motivated and active is not quite there, because you're satisfied, you're content. So a lot of people don't like that side effect of SSRI drugs. For some people, it's worse than others. Another side effect that's kind of hard to get rid of, and a lot of people do like, is it tends to depress your hunger. So if you feel satisfied and content, then that can lead into not being as motivated to eat as you normally would. So some people who have taken antidepressants, SSRI drugs for depression, have found that it tends to decrease their appetite and they tend to lose weight. They want to continue to take the SSRI drug even after the depressive symptoms have tended to go away to a certain extent. So anyway, we can't get rid of all the side effects of these medications. Some of them are still going to exist, and those two in particular, it makes a lot of sense that they're just going to occur, because what serotonin does, it allows you to communicate peaceful, contentment, satisfied sort of feelings. And that can have effects both in sex drive and hunger and perhaps other things as well. Okay, well, let's leave this and talk about how I used this term once already today. We can label this whole process of neurological communication. We can label it electrochemical communication. I like to refer to this as electrochemical communication because that label describes the two major processes involved in neurological communication, and further allows you to see that there's really two major processes: the electrical part that occurs within the axon and the chemical part that occurs within the synapse. And if there are two major processes, we can use one of them as the front door, the gateway into manipulating people's emotional reactions to the world or other kinds of processes so that we can improve their lives. Or we can use the other process as the gateway. Now, when we take an SSRI drug, we're essentially entering into the chemical gateway, and we're trying to initially affect the chemical process that occurs between neurons, knowing that it's going to affect the electrical processes that occur in subsequent neurons down the line, but we're starting with the neurotransmitter process. Most of the medications that we take, or most of the things that we do to help people who have mental illnesses these days, is primarily accomplished via the gateway of affecting neurotransmitter activity. Now, there was a guy way back when in the mid-1900s named Wilder Penfield, a neurosurgeon, who experimented with the electrical part of the process. He would have patients on the operating table, doing some sort of neurosurgery to help them with tumors or other things going on in their brains. And with their consent, he would stimulate parts of the brain, and he would get these patients on the operating table to move parts of their body depending upon which part of the brain was stimulated. He would get them to hear things or to see things depending upon which part of the brain was stimulated. And he began to realize that you could actually map out the brain and see which part of the brain is responsible for what kinds of activities simply by jump-starting the electrical activity that's associated in each one of those areas of the brain. And so he was kind of starting with the electrical gateway, stimulating electrically parts of these brains, and finding out basically what happened, depending upon which part of the brain was being stimulated. So what I'm trying to get to now here is that what that led to is something called deep brain stimulation, DBS. DBS is now being used for people who have Parkinson's disease. It's also being used for people who are depressed and have other kinds of mental health or other kinds of issues, similar issues, as another way of helping these people out. Rather than give them medications, they're stimulating parts of the brain that are not as active as they should be in order to make them work a little more properly. I have a friend who I used to work with at the golf course who had developed an essential tremor in his very young life, in his teenage years, in 20, maybe young 20s. And over the course of his life up into his late 60s and early 70s, this essential tremor just got worse and worse. And he had a hard time doing anything that involved, steady hands. At some point at the end here, before he had the surgery, he was shaking so much. He had tremor so much in his hands that he couldn't button his clothing. He couldn't write anything. He couldn't write legibly. He couldn't feed himself. So his wife basically had to do all of those things for him because he was shaking so much. Now, he didn't have Parkinson's disease, but he had something like it without the other larger, broader problems associated with Parkinson's disease. He just had the tremor. But eventually it got so bad that his doctors said, look, we have this thing now. What we're going to do is we're going to implant electrodes into both sides of your brain, in the parts of your brain that are controlling this motor activity that's causing the tremors. And we're going to stimulate these as if you had a pacemaker in your brain. We're going to stimulate these neurons to fire more readily and at the right rate so that the tremors will be reduced. And I remember at the golf course, when I used to work with him, he would show me after the operation that he had the ability to, through this transmitter, had the ability to turn off the stimulation, to turn it on, to turn it up, turn it down. And while he was doing pretty much okay after the surgery, he says, now take a look at what happens when I turn off the stimulation. And all of a sudden his hands, and this was in the matter of about 5-10 seconds, his hands were moving all over in front of his face. He couldn't stop the movement, and he couldn't touch his nose. He kept missing it. He couldn't write legibly at all. And then he says, "Now watch this," and he just fumbled around, with his hands moving and everything, on this transmitter that he had, and he turned the dial, clicked it another way, and that caused the stimulation to go back on and to be increased. And within seconds, again, 5 to 10 seconds, all of a sudden his hands slowed down, and he was able to touch his nose, and he was able to hold his hands in front of his face with just the kind of slightest tremor, without all the spastic movement. So that's the outcome of Wilder Penfield's research back in the 1950s, and it's an application of deep brain stimulation that's being used today. And as I said, it's also being used for people who have depression and anxiety issues these days. They're finding out which parts of the brain are not working quite right, and they're stimulating those areas with implanted electrodes with wires that run down just underneath the surface of the skin down here to an area in the chest with the control module right here in the chest, and then these people are given a transmitter to be able to control whether or not and the rate at which the electrical stimulation is delivered to those parts of the brain. Pretty amazing stuff. So I would say this is kind of the brave new world of treating mental illnesses, depression, anxiety, and other things like that. We're still going to continue to give people medications, but it might be safer, unbelievably or not, to start with the electrical gateway, to really work on that as opposed to the neurotransmitter gateway in this electrochemical process that neurological communication is. And of course, there's going to be other approaches to treating these kind of mental health issues in the future as well, but these are some of the major ones that we're using these days and beginning to use, particularly in the electrical area. This is the Gary Larson Farside version of Wilder Penfield's research. You can look at that on your own. So I want to just review, though, the neurotransmitter activity here again, because that's really still where we're at. Mostly what we're doing in treating mental illness issues, depression and anxiety in particular, is we're giving them medications, working on the neurotransmitter component of this communication process. So as I said, serotonin seems to be involved in depression. The theory is that if you have depression, you likely have lower levels of serotonin. So if you take Prozac or something like that, it tends to slow down reuptake so that these lower levels of serotonin can work longer in the synapse, and the feelings of satisfaction and peace and contentment tend to be communicated a little more readily. I want to point out that one of the issues with these medications is some of you have had experience with them and it just hasn't been a good experience. I want to point out that serotonin is an element in depression. There's also your whole biochemistry. Serotonin is involved in communication of contentment and peace, and I'm not going to worry about that. I'm not going to stress about that and so on, but so is potassium, and so is norepinephrine probably, and so is, in some indirect way, the amount of sodium in your system, the amount of potassium in your system, and chlorine and calcium, which is affected by the amount of sleep you get, the amount of stress in your life, the amount of exercise you get. And one of the things that you have to understand when we start dealing with the biochemistry that underlies all these conditions that we're trying to treat is that everybody's biochemistry is different. Some people take these medications and they just don't work because their biochemistry is different. Ideally, in the future, we'll get to the point, and we're beginning to get there, it's just going to be a slow process. In the future, at some point, rather than you going to the doctor and describing your symptoms, and the doctor says, I think you might be depressed. So this is what typically happens. The doctor will say, since you might be depressed, and since this medication seems to work for 2/3 of the people who take it, and we don't want you committing suicide or anything like that, and depression can be very debilitating, so let's give you this medication and see what happens. you take it for 6-7 weeks, and then maybe you get reevaluated, and it either doesn't help or it does help a little bit. If it doesn't help, maybe it's because there's something else in your biochemistry that's messed up, and it's not completely in line with the way it should be to allow the SSRI drug to work the way that it should. But anyway, in the future, rather than prescribing the medication just based on symptoms is because they work for most people, they're going to actually test your serotonin levels and see exactly where they're at, and test your other biochemical levels, your sodium, potassium, and chlorine and calcium, and other things in your system, test them all, and then they're going to engineer a drug just for you. So all of these drugs that we take are basically drugs for the generic person, for the generic person who might be depressed. But in the future, hopefully we'll be able to engineer a drug that works for your system, your serotonin levels, in conjunction with everything else about your system. And we're just not there at this point, but eventually we will. And I sense that we'll have a better ability at entering into both gateways, the neurotransmitter gateway and the electrical action potential gateway in the future. But let's talk about some other neurotransmitters. Dopamine is another major neurotransmitter that's involved in memory and movement and pleasure and strong drives. So if you have Parkinson's disease, if you have these tremors, or if you have full-blown Parkinson's disease and everything else associated with that, the theory is that likely it's because you have low levels of dopamine. So if you take L-Dopa, levodopa, what it does is in your body can synthesize that levodopa to create more dopamine. So it increases your dopamine levels, and your Parkinson's symptoms tend to be depleted or decreased.
Just a moment.
Siri. Dopamine is also involved in ADD, so it's involved in thinking.
Sorry, I
and
didn't
memory.
quite catch that. Could you please
Be
repeat
quiet.
it?
So if you have ADD, it's likely because you have low levels of dopamine in another part of your brain, and that's causing you to have difficulty concentrating and focusing and not being impulsive, not being distracted. So those parts of your brain that allow you to not be distracted and not be so impulsive and allow you to focus and concentrate are not working as readily as well as they normally should. So we need to speed up those parts of the brain and increase dopamine activity where the dopamine activity is too low. And so we give an ADD patient a stimulant drug like Ritalin or Dexedrine or Cylert, Adderall. And I know it's highly controversial because it gets overprescribed, and the diagnosis of ADD is probably overdiagnosed. But many people do have legitimate ADD, and there is a biological reason for it. And if you stimulate those parts of the brain that are not as active as they should be, then many of the symptoms tend to be decreased. It's not a cure. It's not the only solution. You need to basically take all of these drugs that we're talking about as a tool to get the body systems a little more in line with the way they're supposed to be, stabilize the person so that the person can take advantage of other interventions like therapy and coping mechanisms, whatever the situation is, and whatever it is called for. Many children who have ADD don't get adequately treated or don't have the appropriate interventions, and so they experiment on their own. They go out and they take street drugs, and they find out that cocaine and other kinds of drugs like those tend to actually help them. And so they're self-medicating. And I firmly believe actually that many drug abusers are self-medicating. Their trying to fix a problem that other people don't have. Most drug abusers are not bad people, in other words. They are simply trying to fix something that's awry in their system. And even though this is pretty controversial, this Ritalin and Adderall being used to treat ADD, I think actually is probably a better thing that these kids are giving these kinds of drugs, and rather than having them go out and experiment with street drugs. Dopamine is also involved in schizophrenia. So in another part of the brain, if you have high levels of dopamine, that may be the reason why you're displaying psychotic symptoms, hallucinations, auditory and otherwise, paranoid thinking. Schizophrenia is the worst mental illness. It's about not really living in reality, going through these phases where your touch with reality is just not very great. So when your thinking gets highly disordered, that may be because you have too high levels of dopamine. Your dopamine activity in certain parts of your brain is too high, and so it needs to be slowed down by taking clozapine or Risperdal. Now, there are other neurotransmitters. Endorphins are neurotransmitters that tend to decrease pain and help us feel a little bit of pleasure. Acetylcholine seems to be involved in movement and thinking and memory. People with Alzheimer's disease tend to have depleted levels of acetylcholine in the hippocampus area of the brain. And acetylcholine is also likely affected in some way when a person has difficulty moving normally. GABA is an inhibitory neurotransmitter. It decreases autonomic nervous system activity so that you're less anxious, less stressed, less in high gear. And people with anxiety disorders take Xanax and Buspar and other anti-anxiety medications to slow down their kind of hijacked fight or flight response to stressors. Glutamate is the most common excitatory neurotransmitter in the brain. Seems to be involved in a lot of things, and it's being implicated more and more in schizophrenia and bipolar mood disorder. And there's other neurotransmitters as well, but those are some of the major ones that you should know something about. Now, if we talk about the brain is nothing more than a whole bunch of these neurons. Electrical activity causing chemical activities between neurons, causing electrical activity in the next neuron, and so on all the way down the line. It's just a whole bunch of neurons that act in the way that we described earlier. We can break the brain down into different parts. The most basic primitive parts of our brain are the brainstem area, or the hindbrain, as it's called in the book, just to a certain extent. The hindbrain and the brainstem area includes the cerebellum, among other parts. The cerebellum is involved with balance and orientation and movement. Also incorporates the medulla. The medulla is involved in life-sustaining reflexes, the ability to cough and sneeze and digest and pump blood and perspire. Those are all things that we call vegetative reflexes that we need to be able to do in order to live. If you are totally dead, not just what they call brain dead, but if you're totally dead and you have to put you in a coffin, then your medulla is not functioning. But if you're brain dead, which is kind of a misnomer of a label, what that likely means is that the rest of your brain is dead, but your medulla is still active. Your heart is still pumping blood. Your stomach is still digesting food. And sometimes people can live in that state, that brain dead state, vegetative state, persistent vegetative state for years and years and years. There was the famous case several years ago of Terri Schiavo down in Florida. Her ex-husband, she was in a persistent vegetative state for 15 years. And occasionally she would smile. She would track objects around the room. Her ex-husband said, look, she needs to be taken off all these life support systems. She needs to be stopped being fed because she would not have wanted this. And there's really no life there. But her family and I can appreciate this because I remember when my father was brain dead after a stroke. For the first few hours, maybe the first day or two, it seemed like there was still some of this vegetative reflex stuff that was still there, and it was easy to question the doctor's diagnosis that he was brain dead. Anyway, Terri Schiavo's family, not wanting to lose her and always wanting to maintain hope, says, no, we're not going to stop feeding her. We're going to keep her alive and allow the medulla to keep functioning so that we'll hold out for this hope that maybe she'll eventually come back. Well, eventually it went to the courts and the ex-husband got his way and she was not fed anymore. It generally takes a week to 2 weeks, depending upon the health of the person, overall body health of the person. But after a week to 2 weeks of not feeding, then eventually the person dies. Anyway, after she died, they did take a look at her brain, and basically what they found was that all of these areas up in her brain here were basically depleted substantially, and she had large areas of cerebral spinal fluid where there otherwise would have been tissue in the past, but it atrophied, it eroded, and it pretty much disappeared. The brain is a kind of a use it or lose it kind of an organ. It's like a muscle. If you use it, it develops, it tends to exist, but if you don't use it, it tends to atrophy away. And that's essentially what happened to her after 15 years of being in this persistent vegetative state. So I think her ex-husband was vindicated that there was no life there. There was no neurons up here. I mean, there wasn't the massive neurons up here that would allow her to think and to feel and to express emotions and to be human. There was no quality of life, even though she had these vegetative reflexes working for her because her medulla was still working. So that's the case with somebody who's brain dead. Their medulla is still working even though the rest of the brain typically is not. Now, the reticular formation, or the reticular activating system, is the system that allows you to come in and out of consciousness, to go to sleep, to wake up, to be fully aware and alert, and then to kind of zone off and not really be involved in what's going on, such as what happens, when students kind of zone off in the classroom, or maybe what you're doing now as I'm lecturing. The reticular formation allows you to go back and forth in terms of awareness and alertness and consciousness. And so if you're in a persistent vegetative state, your medulla likely is not working, is working, but your reticular formation is not. And that's the reason why you can't arouse yourself out of this persistent vegetative state. So this picture, when you look at it, shows the cerebellum at the base of the brain and in the rear of the brain, and the spinal column going into the base of the brain. The medulla is the very top of the spinal column going into the base of the brain, and the reticular formation is underneath the medulla and within, deeper into the spinal column at the very base of the brain. If you go a little higher into the brain, above the roof of your mouth, between your two ears, in the very middle of your head, you have the limbic system, the part of your brain that's involved in emotional control, information processing, information transfer. It's a less primitive, more human part of the brain, and it includes, among other organs, it includes the hypothalamus. The hypothalamus seems to be involved in strong drives, hunger, thirst, and sex, as examples. So when you take Prozac or an SSRI drug, it tends to stimulate or allow for a more serotonin activity because it's blocking reabsorption of the neurotransmitters. It tends to actually cause that to happen within the hypothalamus, which is one of the reasons why one of the side effects of taking an SSRI drug is your hunger tends to be decreased. Years ago, people took a drug called fen-phen, two drugs actually, phentermine and phenylalanine, something like that. They took these two drugs together to decrease people's appetites who were dealing with weight issues. And what that tended to do is that it increased serotonin activity in a way that the brain was fooled into thinking that the person was full when messages from the stomach were basically saying, no, I need to eat. So the brain getting this increased serotonin activity in the hypothalamus, the body doesn't need to eat when it really does. They took those drugs off the market because they were associated with heart valve defects, and the drug manufacturer didn't want to get sued like crazy, and so the drugs were taken off the market. The hypothalamus also has been implicated in the past in sex drive and sexual orientation. So a guy named Simon LeVay in the early 1990s did brain research on cadavers, 41 cadavers who had died, obviously. Some of those cadavers were gay males, some of those were heterosexual males, and a few were thought to be were known to be female, and they were thought to be heterosexual females. And what he found was that in this part of the hypothalamus, which is known to be involved in sex drive to a certain extent, the cell size, which was about a third the size in the gay males as was the case in the heterosexual males. So the gay males had a smaller cell size, and their smaller cell size was more typical of the heterosexual females in the study. So in other words, they had a feminized brain in terms of the cell size in this part of the hypothalamus. And by implication, what Simon LeVay determined was that gay females, lesbians, tend to have a larger cell size than normal for females. And it was more like the heterosexual male. So their brains, this part of their brain, was masculinized. So he said that this was the cause of homosexuality. Of course, we now know that homosexuality, sexual orientation is very complex. It likely involves some biology, and this may be part of it, but we don't really know for certain. But I think you're right. That research does show whether it's a major part of sexual orientation or not. It does show, his research does show that the hypothalamus likely has to play some role in sexual orientation. The hippocampus is involved in memory. As I said a bit ago, acetylcholine tends to be depleted in Alzheimer's victims, particularly in the hippocampus area. Later on, when we get to the memory chapter, you'll get a chance to watch the Clive Waring video. Clive Waring was a man who developed encephalitis when he was an adult with a child, married with a child, and he was an accomplished conductor of a London symphony. Very well known, very talented, but this encephalitis basically inflamed his brain, heated it up, and caused basically the death of most of the cells in his hippocampus. The result of that is that he began to not remember basic things, his daughter's name, most of things that he had known in terms of information or in the past, learned and acquired through reading and studied and just keeping up on things. His memory for those things had basically begun to disappear. But what he retained was his ability to walk and talk and play the piano and conduct music. He didn't even have a memory at all that he could conduct music and he could play the piano, but he could still do those things masterfully. So what it was determined with him was that since his hippocampus was destroyed, that affected his ability to remember facts and information and the events of his life. But he retained his ability to remember the conditioned memories and the procedural memories, the muscle memories, if you will, that he had gained through his life, indicating that the hippocampus is involved in event memory and facts and information, but not important in skill memory, procedural memory, and muscle memory. As you'll see in the video, one of the interesting things is that when his wife walks in the room, he automatically recognizes her and knows he loves her and treats her in a way that's different from other people. But when she says that she was there 10 minutes ago, does he remember that? And ask him if he remembered that. He'd say, no, this is the first time I've ever seen you in my life. Well, how do you know you love me? Oh, I just know that. So he doesn't remember anything they've ever done together, but he remembers that he loves her. She eventually actually divorced him because the lifestyle was so rough. Him living in an institution and her being completely healthy and still relatively young. She, after living in the U.S. for a couple of years, she decided that she still loved him, and so she went back and remarried him. And he doesn't know to this day any of that. He just knows that when she walks in the room, he loves her, and he showers her with love and attention and hugs and kisses. And then he does the very same thing the very next time that she walks in the room, even though it's only been separated by 10 minutes. He doesn't remember the previous time. He doesn't remember anything because his hippocampus, other than procedures and skill memories and things like that, because his hippocampus was damaged. The amygdala is an organ in the brain that tends to be involved in memory and strong emotion, rage and fear and high anxiety. People who have post-traumatic stress disorder likely have an overactive amygdala that's not tempered and slowed down by frontal lobe reasoning and processing. People with extreme anxious reactions to stimuli probably have an overreactive amygdala, a hijacked amygdala. Again, that's not effectively, appropriately tempered by other processes in the brain. The thalamus is basically a information way station. So all of these sensory systems send their impulses through the thalamus, through the rest of the brain, except smell. It's thought that smell is a very primitive sense, and that it needed to be in our way past. It needed to have direct lines into the rest of the brain in order to be able to respond very quickly and broadly to inappropriate or dangerous stimuli as indicated by smell. And that's the reason why it goes directly to the brain as opposed to through the thalamus. But the rest of the sensory systems send their neurons through the thalamus to the rest of the brain. Okay, backing up. Now, higher up in the brain, we get into the cortex. The brain in the cortex is made up of 4 major lobes. The frontal lobe is the largest of the 4. In the book, you can read about Phineas Gage. He was involved in a railroad accident where this metal rod shot through his head and basically destroyed his frontal lobe. They say that although he lived for several years after, he wasn't the same person after that. His personality changed. He was less emotionally in control. He was less conservative, less practical, and he was much more prone to temper tantrums and irrational behavior. That case study, along with other research, has shown us that the frontal lobe is involved in many of the higher order processes that make us human. The ability to think rationally and logically, to plan, to organize, to be in control of our emotions, and to exercise inhibitions over things as a result of things that we've been taught or that we just kind of know to be right or appropriate. The frontal lobe, the very front part of the frontal lobe, is the last part of the brain to develop, and that's not really complete until the mid-20s. That's led some researchers to say that the reason why adolescents tend to be engaging in more risky behavior and less practical and more emotional than they will be later in their adult life, it's because the rest of the front part of their brain is not developed yet. That part of the brain that allows them to be more practical and in control of their emotions and their inhibitions. It's not completely developed until mid to late 20s. The frontal lobe also includes the motor cortex, which allows us to move. The very back part of the frontal lobe is where the motor cortex is. The parietal lobe is right behind the motor cortex and right behind the frontal lobe. It's where we sense pain and temperature and touches and other kinds of sensory skin-related sensations. The occipital lobe is in the very back of the brain. It's where we sense vision, have vision. It's the smallest lobe. It's the one that's most specialized. Primarily, the occipital lobe is about vision. The temporal lobe is right here in your temple area. It's where we have audition, where our ears send their information to allow us to hear. Really only a small portion of the temporal lobes is where audition is. So a lot of the areas otherwise are involved in information processing and organizing and just all the work that the brain is doing. It's not really completely specialized. And the same is true for other areas of the parietal lobe and the frontal lobe that are not associated with motor or sensory input or something very specialized. You have all these other areas that we call association areas that are just kind of broadly used in the brain to accomplish all sorts of things. The frontal lobe, parietal lobe, occipital lobe, temporal lobe have a lot of these association areas. The occipital lobe pretty much doesn't have a whole lot of association area. It's pretty much all vision. So this happens to be my brain. In 2016, a little over 4 years ago, I was involved in an ATV accident. I kind of got knocked around and didn't think too much about it except that I had massive headaches immediately, and they lasted for a couple of weeks. And toward the end of the couple of weeks, I started losing my memory for passwords and things like that, and just not functioning all that well. And that ultimately led to a full-fledged stroke about exactly 2 weeks after the accident, and I ended up in the neuro ward, the ICU, for 8 days, where they ended up vacuuming all these blood clots out of my brain because I had torn my carotid artery, and it slowly clotted to the point that it shut off all the blood supply to my right hemisphere. And they say that you lose 2 million brain cells for every minute that they're deprived of oxygen. So I figure I lost about 300 million brain cells in my right frontal, temporal, and parietal lobes. And you can see that these are ventricles here, but this is the cortex here. This is normal this is the left hemisphere, so it's the opposite. And the right hemisphere, this white area here, is dead cells. And this is a little bit lower in the brain. You can see that it's the dead material is more into the frontal lobe. This picture down here, you can see that all this damage here, again, that's the right hemisphere, goes from way down here all the way up to here, so it's quite tall. And anyway, this is a PET scan. Again, shows the damage on the right hemisphere here and here. Not a lot of brain activity in these, where you see these blue areas. Again, these blue areas here is cerebral spinal fluid, so that's normal, but this is definitely abnormal. So I'm okay. I function okay. Physically, I'm fine, but I can't do a lot of multitasking. I can't do a whole lot of screen work, extreme mind-bending activities, a lot of stimulation, just a lot of noise, a lot of things going on around me tends to wear out my brain. And I think I'm pretty much intellectually the same as I was before, but I just don't have as much capacity to withstand a lot of stimulation. There's not a day goes by that I don't feel incapacitated by it, but I'm managing okay. All right. I know people that have had strokes through being in touch with stroke support groups, people that have had strokes who they can't see anything from on the right visual field, or they can't see anything on the left visual field. Many of them can't drive. Many of them have had to quit work. I was off work for a year and a half completely, and then came back part-time, and then it took another year working part-time to come back full-time. So I consider myself lucky, but I have to tell you, it's been a pretty devastating change in my life to have to deal with the effects of the stroke, and it's never going to go away. I thought eventually I would get better completely, and it would be just a distant memory, all the issues I'm dealing with, but now I now know that I'm stuck with this for the rest of my life, but I'm still alive, so I can't complain too much. Now let's talk about the fact that there's actually 4 lobes on each side of the brain, so there's really 8. You have a right frontal, a left frontal, a right parietal, left parietal, and it turns out that the right version of each of these lobes tends to process information a little differently than the other side. Michael Gazzaniga is probably the major researcher that's taken a look at the 2 hemispheres and how they operate a little differently, and what he did over the years. And I'll try to show you this video on my PowerPoint so you can see this yourself. What he did was he was able to show that if you take a person who's had the corpus callosum cut between the 2 hemispheres of the brain, the right side and the left side, so that there's no communication between the 2 hemispheres, you can show that the right side operates a little differently, processes information a little differently from the left side. So the reason why they cut the corpus callosum in some people is because these people have epilepsy, and their epilepsy is out of control, and nothing seems to really work to reduce their seizures. So if what happens with seizure activity is this kind of electrical storm of activity may occur in one side of the brain, in a particular spot in the brain, and then that causes other activity in other parts of the brain. It kind of jumpstarts other activity in other parts of the brain, and pretty soon the whole brain is kind of going haywire with all this electrical activity, and that causes the seizure. So if you cut the corpus callosum, then if the electrical activity that's going haywire starts on, say, one side of the brain, it's not allowed to go to the other side of the brain because the communication links between that hemisphere and the other one are cut. And that tends to decrease people's seizure activity by relegating the electrical storm that's abnormal to one side of the brain. But once the corpus callosum is cut, they can have people then watch a screen, and they focus on a dot in the middle of the screen. And without blinking and just focusing on that dot, if a picture is shown to the right side of the screen, it goes to the left hemisphere, and it's not shared to the right hemisphere, and so the left hemisphere is being a piece of information that the right hemisphere doesn't have, and vice versa. It turns out that if something is shown to the right hemisphere, right visual field, it goes to the left hemisphere, and the person is able to say, well, what do you see there? And the person is able to say verbally, quite readily, what was seen in the right visual field, what was seen in the left hemisphere. But if something is shown in the left visual field and it goes to the right hemisphere, the person is not able to label it verbally. So what Michael Gazzaniga was able to show is that language, or at least the executive function of language, seems to be in the left hemisphere for most of us. This is where we primarily talk from, and we have the ability to label things. So the interesting thing about this is if you show something in the left visual field, it goes to the right hemisphere. The person with a split brain is not able to label it, but if the person is then asked to draw a picture of it with his left hand, keeping in mind that the left hand is controlled by the right hemisphere, and the right hemisphere actually knows what image that is but just can't label it, the person is able to draw a picture of what's in the right hemisphere. He just can't label it. Same thing happens when a person with a split brain is sitting at a table with a curtain over his hands. If objects are placed in the 2 hands, but he can't see them, but he can recognize what they are by touch. If a pair of scissors is put into the right hand, and then he's asked, okay, what's in your right hand? Then he's able to say that's a pair of scissors. But if the scissors are put into the left hand, he's not able to say those are scissors because the information is then going to his right hemisphere. and the word scissors is not able to be found on that side of the brain. But if the researcher says, okay, now put down what's in that hand and draw a picture of what's in the left hand, the person's able to draw a pair of scissors with his left hand, because the left hand knows what the right brain knows, but the right brain just can't label it. So anyway, that shows that language seems to be a left hemisphere activity. Other research has shown that the right hemisphere allows us to see faces. Sometimes people have strokes, and they can recognize people via other means, through their voice, their clothing, their other overall appearance, their body center, something like that. But when they look at it, just their face, they can't recognize them, because that part of the brain just is not working quite right. That part of the brain tends to be on the right hemisphere. So in general, that's consistent with what we now know, that the right brain tends to process information more holistically in terms of overall meaning, and tends to be very strong in visual spatial tasks, whereas the left hemisphere is more logical and sequential in the way that it processes information, and again, it allows us to use language. I've seen videos in the past of people with split brains, how they act. This one video shows a woman in the hospital after the operation, and somebody places a lit cigarette in her hand, and she picks it up and puts it in her mouth and starts to smoke it. But immediately after taking a drag on the cigarette, the other hand comes in and pulls the cigarette out of the mouth and stuffs it out in the ashtray. So what they figured out is that half of her brain, one side is a smoker, the other side is not a smoker. Some researchers have also indicated that at the very first, when these people are trying to get used to the fact that their brains don't share information like they used to do, they'll be reaching in the closet to pick out items to wear, clothing to wear, and the right hand picks out an outfit, the left hand picks out an outfit, and what they pick out is different, because the right hemisphere tends to be a little more creative, a little more flamboyant and less conservative. The left hemisphere tends to be a little more logical, and so the right hand, controlled by the left hemisphere, pulls out the pinstripe. The left hand, controlled by the right hemisphere, pulls out the paisley. Sometimes people will say initially, after the split brain surgery, that they'll be trying to button their shirt with one hand and unbuttoning with the other hand, because they have like two brains. After a while, they kind of get used to this and they work it out. This kind of gives us, but this whole thing kind of gives us another look at the unconscious. Freud, when he focused on the unconscious, he was mainly focusing on the id and our animalistic tendencies. But another way to look at the unconscious is there's just a whole lot of processes that go on in the brain that we're not aware of, because they're subvocal, because they're just not really conscious. They just sort of happen. And what this split brain research suggests is that there's a whole bunch of activities going on that basically occur in the brain that allows us to decide what objects to wear, and to button our clothing, and to smoke or not smoke and live with it. But somewhere in there, there's one side of us that doesn't want this outfit, but does want this one, or does want to smoke or doesn't want to smoke. And we have this constant sort of interaction of kind of debates and arguments going on about what we should do and how we should behave. And most of it we're not aware of, because it's unconscious. It's kind of underneath the surface. But these split brain patients kind of have to act out all those things, all those arguments and debates that are normally unconscious for most people. They have to act them out at the level of the hands and out here at the level of the senses, as opposed to internally in the brain, where it happens for most of us. So anyway, that is kind of an interesting, fun look at some of the implications for some of this brain research. But I just want to point out that most of the research says that it makes no sense to label people as being right brain or left brain based on their characteristics. Some people are just more linguistically inclined. Some people are more visually, spatially inclined. Some people are more logical. Some people are more kind of creative and non-conventional. That doesn't mean they're right or left brain primarily. Most of us are using all of our brain all the time. And if we didn't use them all the time, those parts of the brain we didn't use would atrophy and wear away and erode. And that's the best way to function, to use all of our brain all the time and integrate the two, not to try to be or even label somebody as being right brain or left brain. All right, that's the chapter. I'll see you next time.